she is among the first Egyptian to be recognized as cognitive behavioral therapy diplomate and member to the Beck Academy of Cognitive Therapy in USA. She is a member of the psychotherapy section in WPA. Dr. Raham is founding member of the Egyptian Association for Cognitive Behavioral Therapy. She was appointed president to Egyptian EACPT from 2013 date of establishment till current date. 2023, Dr. Raham Ali has presented and represented Egypt in several national, regional, international events. She is a leading educator and a trainee for cognitive behavioral therapy for many regional academic and specialist institutes. She is a very famous psychotherapy therapist in Egypt, especially in cognitive behavioral therapy. Welcome, Dr. Raham.
Good morning, everyone. Thank you, Professor Mumtaz, for this general and generous invitation. It's an honor, actually, that Dr. Mumtaz Abdul Wahab says that I'm his friend. It's actual, he's our dear professor. We have all learned from him a lot. And I am a graduate of Asr al-Aini Medical School in 1999. And please don't count it and know my age, okay? But my PhD degree was awarded by Ain Shams University. Thank you very much, Dr. Mumtaz, for your kind introduction. My presentation today, actually, and thank you all for coming after breakfast. I hope you had enjoyed your breakfast all, because it's the very first session of the last day of the conference. So it's actually an honor to have an audience there. Thank you very much. The presentation today is going to be about the role of cognitive behavioral therapy in psychosocial rehabilitation. As this is a conference all about the psychosocial rehabilitation techniques and program, so is there a role for cognitive behavioral therapy in programs of psychosocial rehabilitation for psychiatric patients? If anybody thinks there is a role for cognitive behavioral therapy, please raise your hand. Thank you. It's a minority. So the rest does not think there is a role of cognitive behavioral therapy in psychosocial program? Am I correct? You don't think there is a role? Let's say yes or no. If somebody does not think there is a role for cognitive behavioral therapy in psychosocial rehabilitation, why would you think so? Why do you think there is no role for cognitive behavioral therapy? And everybody is still asleep. Okay, so let's find out the answer for this question. Okay, psychosocial rehabilitation programs in general and psychotherapy are often used concurrently, despite the general notion that these are two different programs. These are usually part of any person's mental health care. Any person who is presented to receive the service of mental health care in one point or another will receive some sort of what is called the rehabilitation and what is called as a psychotherapy, despite the techniques of it. Because rehabilitation, in its own definition, it is trying to improve the adaptability skills of someone, especially with someone who is suffering from a psychiatric disorder, which is mostly a chronic or an acute disorder. Do you think psychiatric disorder in general, the majority of psychiatric disorder are acute or chronic? Acute? Both, in majority. Are they acute or are they chronic? Okay, who says chronic, please raise your hand. Okay, the rest is still asleep. Okay. But the relationship between cognitive behavioral therapy in specific and psychotherapy in general and the role in psychosocial rehabilitation program is clearly from your answer and from your responses has not been systematically addressed. So the historical misunderstanding that psychosocial rehabilitation is helpful only for people with severe mental disorder, that is psychotic disorder, schizophrenia, bipolar disorder, for chronic and severe mental health or psychiatric disorder, while CBT is helpful only for people with milder mental disorders. Actually, the truth is the recent researches has proven that CBT, and I'm a big advocate, of course, for CBT, is not only helpful for mild to moderate psychiatric disorder, it is helpful for chronic psychiatric disorder, it is helpful for medical disorders, including patients in cancer, and including patients facing severe life-threatening position. And to be actually honest, the recent trend of cognitive behavioral therapy is what is called positive cognitive behavioral technique. A positive cognitive behavioral technique is not actually addressing patients. It is addressing what you can say a normal or a non-patient individual, but with symptoms that he would like to improve to reach his better aim in life and his better goal in life. So CBT during the past, I don't think like 50 years, has proven to be not only effective for acute or mild to moderate psychiatric disorder, but in helping anyone to reach a better place in his life. So, as we said, service users usually receive more than one of these interventions, the rehabilitation or the cognitive behavioral therapy, at any given time when they are into the service provision system of mental health disorder. As we said, in trying to defining what is cognitive behavioral therapy and what is psychosocial rehabilitation, we can find an answer or shed some light into if these two perspectives can have common aspects or they are very different from each other. Psychosocial rehabilitation, here it is abbreviated as PSR, psychosocial rehabilitation, is enhancement and maintenance of adaptive skills and environmental support for people with mental disorder. Okay. I know many of you is working as a psychotherapist despite the milieu or the program that is your professional is. But aren't we always trying to help our patient to increase his adaptive skills, to increase his skills in life in general, given what kind of these skills that we are trying to help? So psychosocial rehabilitation in its core nature is enhancement and maintenance of adaptive skills, plus environmental support. What is environmental support? And guys, this is a conference for psychosocial rehabilitation. We should all know the definition of psychosocial rehabilitation for people with mental disorder in order to help them become state satisfied and successful in their environment of choice. Aren't this the aim of every type of psychotherapy in general? Okay. I love side talks. I do love side talks because they must be saying something very important. Okay? Can you please share with us? If you have something to reflect, can you please share with us? What do you think about this?
I'm just thinking it's very interesting that the adaptive skills is very important, and the environmental support as a social worker is very important to be dealing with our cases in teaching them or delivering some adaptive skills toward a better solution.
Thank you very much. Thank you very much. Psychosocial rehabilitation, the only thing that makes psychosocial rehabilitation very specific, or what is a specific item about psychosocial rehabilitation, is not the improvement of adaptive skill, because this is actually the role from day one we meet our patients, to improve skills, to improve skills, to improve skills. But what's very specific about it is the environmental support. We are trying to put them in a better environmental state that is adequate to their current status of a skill or current situation. Because the fact that these are patients suffering from mental disorders that will by default affect their skills, that they will need some sort of environmental support. And this is just a fact. It is not a judgment, but it is a fact. So they become satisfied and successful in their environment of choice. While CBT in general is the enhancement and maintenance of self-awareness. What does CBT means by enhancing self-awareness? Doesn't we all know what we are or who we are? Does anybody in the audience does not know what he wants in life? Is anybody? Okay. So actually, it is using this definition is a little bit deficient because CBT uses self-awareness to be to effective management of interpersonal and intrapersonal skills. So it's like a program, a managerial program to improve the skills of any patient to become a better manager. Better manager, not a manager of a firm, but a manager of himself, of his intrapersonal environment and interpersonal environment. Because it is through self-awareness, supposedly, that a person can now know how to handle his thoughts, how to handle his emotions, how to guide his behavior, if he's lucky enough, with this intelligence, to guide his behavior to where he's going. And I think yesterday when we were having our case, we know that sometimes our mind may play tricks on us, and sometimes our behavior may get us actually further away from our goals. So CBT is enhancing and maintenance of self-awareness in the aim of effective intrapersonal and interpersonal. Again, the golden word here is skills, in order to reduce mental suffering and advance independent functioning. I truly believe that these two different definitions are actually using more or less synonymous terms. But the golden term or the keystone term here is the word skills. Both actually programs or both actually approaches to helping our patient does recognize one thing, that no one is fully independent. No one. And no one is supposed to be fully independent. We will actually need each other in some sort of our aspect. Everyone is interdependent. We are not dependent. We are not codependent. We are interdependent on each other and on our environment to some extent. So when I need help, do you think it's normal that I need help? I'm not weak. Maybe I'm weak, but I'm weak at this point, so it's not a big deal. But the concept is that we are all interdependent on something or on someone is another key term in these both definitions. So for both terms, as actually said, they share a focus on the personal skills, development and maintenance, mainly social skills, because this is actually what we use in dealing with our environment. It is social skills. Who categorizes himself as his good or best or excellent 10 over 10 of social skills milieu in general? Who is very good at social skills? You think he's very good at social skills? Who thinks he's very bad? Bad or intermediate? Halfway. Thank you very much. So halfway is excellent. So there is what in management science, what you can say is a room for improvement. That's what in management, what they say. There is what we have, what I have, and there is still a room for improvement for me. Is that correct? Okay, that's excellent. You are very brave, by the way, just to admit this. So these skills, development and maintenance, despite how good you are, how old you are, okay, there must be some room for improvement for you to do some work on it. And these are mainly social skills. Again, what are the social skills? Does anybody here, and we are all psychotherapists, psychologists, psychiatrists, what are the social skills? دكتورة داليا قولي لنا حاجة. قولي لي واحدة. Thank you very much. Thank you very much. يعني ايه communication skills? Thank you. Thank you. Thank you. Thank you. So this is category A, and they have many subtypes around مثلا like 10 مثلا subtypes of communication skills. Just communication skills, how to ask. Just how to ask for something, how to say no for something, how to start a conversation, how to accept a compliment. These are all skills. Skills that we are not born with. Nobody is actually born with these skills. It is skills that required ايه يا دكتورة داليا؟ Learning. Thank you very much. It's training. Okay, it's a training. It's not what you can say. It's not a gift. We are not born with it. It is something that you have to do some training on to reach your best at it. So, in promoting skills, psychosocial rehabilitation addresses skills that are practical functioning, including basic instrumental activities of daily living, work, socializing, and more. Again, with the problem of synonymous term. So, if we are using skills in our everyday life, day-to-day living activities, so these are called what? Skills in mathematics? Skills in, I don't think, in cooking. These are social skills because it actually involves other persons. So it is social skills more or less, while CBT addresses another different type of skills. It's skills of emotional, cognitive, and behavioral functioning, including emotional regulation, blah, 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 and behavior management. So it does not only include the interpersonal skills, which might be called social skills, it again includes managerial skills of managing the internal environment of someone, including his thoughts, his emotions, and his behavior. And nobody actually can see this. They can see the consequence of it. When I see someone, when I interact with someone, I see how good a manager he is in dealing with the internal environment. This and this and this. Okay, these skills, of course, overlap. The practical and what is called behavioral functioning are not only similar, that it sometimes can be identical. Social skills, interpersonal effectiveness. Oops. Sorry. طب خلاص. Okay. For this, do you think asking for help, the skill for asking for help, is a practical or a social skill? Both? Both. Okay. Thank you. What do you mean by both?
Practical is the way, a mechanism. So practical, it would be a mechanism, technique, how to deal with it. And social, as you guys mentioned before, the communication, interaction.
Thank you very much. Thank you very much. Thank you very much. So unless in every skill that you are dealing with a person, that it does have a portion, a part that is a practical skill, and the other part that is a social skill. A social skill, it's how you do it. Okay, the practical skill is how you do it, and the social skill is because you are doing with another person, so you have to take into consideration the other person and how he will receive this and how he will receive this. I just mentioned the ask for help skill because this is one of the very, very common difficult or easy skills for everyone. Do you think it's difficult or you think it's easy? Very difficult. Why it is very difficult? Thank you. Why do you think it's difficult for most of us to ask for help? Okay, and does anybody knows everything? Is there someone who knows everything? He's good at everything? So it's actually... Thank you. Thank you. Thank you very much for this. Because they have the misperception of someone else will negatively judge them if they ask for help, while actually, if somebody comes to you and asks for help, would you think that he's weak? So why do you get the idea? Why do you get the idea that he would think you're weak? Exactly. It's another story. It's another story. But actually, when somebody comes to us and asks for help for anything, we are flattered because we think that he now acknowledges that we know something more and that we can help him, and we just admire it and feel good about ourselves. But on the other hand, because we see this as a sign of weakness, which is actually not, because as a fact, nobody knows everything. We still don't want to, there is a barrier in doing it. So, okay. Dr. Hisham is watching his watch. Yes, please.
A very humble comment. I think in this interaction as well, excuse me, we are biased. Yes. That's one thing. So we bring our own knowledge accumulated either by reading material or education. And I think if you have yourself as a therapist, you have your experience living through these mental issues,
yes.
I think you have a better insight to provide help. So I think that's another comment that...
Thank you. Thank you very much. Thank you very much. Well, actually, the aim of this presentation is just to raise so many questions in your mind, so you leave with so many questions while you came with so many certainties, and I'm just checking all certainties. So for self-awareness, both the psychosocial rehabilitation and CBT again have some common ground. Where psychosocial rehabilitation programs in general, the readiness for a patient to start this psychosocial program involves some sort of self-awareness of one's personal goals and related matters and his current status. Again, there is a common ground between psychosocial rehabilitation and CBT. While CBT starts with self-awareness, but psychosocial program needs a patient to reach this self-awareness state in order to start the program as well. Okay. The shared focus, I hope, is now a little bit more obvious that both share a focus on skill development and maintenance in general. So both of them may be productively combined by synerging each other, perhaps similar to other synergisms within psychosocial rehabilitation. What are the other synergisms in psychosocial rehabilitation program? What do you think there are other? Because psychosocial rehabilitation is a holistic program that includes environmental as well factors. What do you think there are other synergisms within the psychosocial program? Of course, there is employment, there is housing, there is stuff like this. If a patient needs someone from a social service, these are the specific other synergisms within a psychosocial program. Okay, I was just trying to find a program that is very specific and illustrated for psychosocial program to find out the common grounds. This program is, I think it's French. It's called Rehab Best or something like this. It's in France. It's a program, this is the prior stage for the program, where the patient is, of course, assessed at many levels: neuropsychological, medical, autonomy, if the person can live with himself alone or not independently, occupational, can he work at any level, and these are sensitized in one program. Here the program included psychoeducation. Is psychoeducation part of CBT, or am I mistaken? Does anybody know CBT? طب احنا خلاص we don't know قوي psychosocial rehabilitation, but CBT psychoeducation is actually a common stone in all kind and all stages of CBT. Well, actually, CBT sometimes is mistaken as an educational program, a training program where education goes on in every stage by every way. We try to teach our patients something. Again, there is cognitive remediation. And I can see the term cognitive. I can see the term cognitive. Social skills training, cognitive behavioral therapy, mindfulness. بتوع الدي بي تي هيزعلوا مننا بقى. mindfulness هنا بيعمل ايه؟ دكتورة داليا. طب in simple words بس can you please يعني inform us what is mindfulness؟
هو بس انا عشان كنت في فتره في فرنسا فانا عارفه البروجرام ده بيشتغل ازاي.
اشكرك.
كان مينلي ادابتد على سكيزوفرينيا.
ايوه.
البارت اوف سايكو اديوكيشن كان بيتعمل جروبس تو اكسبلين وات از ذا ديس اوردر. كوجنيتيف ريميديشن عامل زي البرين جيمز كده، مايند جيمز بيعلموهم حاجات فيها ماثيماتكس.
بيعلموهم. Thank you for using the word.
بيعلموهم وبيبقى في زي exercises.
It's in English they are teaching their patients.
Sorry, I'm
لا
speaking. I have to speak
that's
in
okay.
English. So like small exercises to learn new behaviors.
Thank you.
How to use mathematics.
Thank
how
you.
to use thinking to solve some problems.
Thank you. Thank you. It's a problem solving technique. Thank you.
Regarding the mindfulness part,
it's
about how to stay in the present moment, because most of the schizophrenic patients, they wander with the delusions and hallucinations.
So يعني my ignorance, what does it mean to stay in the present moment?
Not allow our brain to wander in the past or the future without being able to use our five senses to stay in the present moment.
So it's like physically to use our physical sensation to focus on what is happening now.
With my senses, my emotions, and my thoughts.
Everybody is now encouraged to share their input about mindfulness. Go ahead, please. Okay. Okay, thank you very much. Thank you very much. Do you have something else to share?
Famous quotation, I don't know, for Delhi. You know, when I think about the past, I get depressed. When I think about the future,
I get
anxiety.
Well, it's not a quotation. He's just describing most of us. Okay, so don't you agree that most of these elements are more or less cognitive or behavioral elements, more or less, not just not listed as a cognitive behavioral program, but mainly they are more or less relying on the cognitive and behavioral techniques, okay? And this is an example of CBT for tinnitus. For tinnitus, with medical problem with hearing, because now CBT can help patient with chronic medical disorder to live a good life or a better life. I'm just putting it for your example. It's again educating, okay? It's again enhancing motivation and commitment. It's again intrapersonal management of thoughts, emotions, and behavior. And it is blah, 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 to end with social skills. So, to conclude, combination of psychosocial rehabilitation and CBT does seem promising theoretically because they both address skills, intra and interpersonal skills. But to speak the truth, more research is of course needed. This research can prepare the ground for more theoretical and rigorous empirical study of how to combine or to synergize each other, and to explore what actual skills are addressed in each a different skill in a psychosocial program and in CBT, and find if there are overlaps and other commonalities between them. Thank you very much for your attention and for being here. Thank you very much.
Thank you very much for Dr. Ariham. Very interesting lecture, and she introduced to us about the cognitive behavioral therapy. Can I invite my dear friend, Dr. Professor Hisham Rami, to help me and to assist me in the chairing this session and to introduce me? Because it's very difficult.
Because Professor Mumtaz is the chairperson, And he's the speaker, so he needs some help in introducing himself. It's not nice to introduce yourself. Yeah. So I'll do this. Huh? Do you have the CV? I will introduce Professor Mumtaz without reading the already known CV about him. Very shortly, very briefly, Professor Mumtaz was born in 23rd of July, 1952, a very famous day in the history of Egypt. We turned from monarchy to being a republic. And now Professor Mumtaz is the president of the Republic of Psychiatry in Egypt. He's the president of the Egyptian Psychiatric Association. Professor Mumtaz graduated from the Faculty of Medicine, Qasr al-Aini, Cairo University, the first school of medicine in Egypt. He is a chair professor, the past president of the department, and now an emeritus professor in Cairo University. He was the vice president, secretary general of the Egyptian Psychiatric Association, and now he is the president of the Egyptian Psychiatric Association. He is the past president of the Arab Federation of Psychiatry. He is a member of the High Committee in Egypt for fighting stigma, the High Committee in Egypt for combating the problem of substance use, and he's also a member of what is known as the National Mental Health Council, the body responsible for applying mental health laws in Egypt. He is also the president of the first regional mental health council responsible for Cairo, Giza, and Qalyubiyya, which is the largest populated area in Egypt. He's an expert in both psychotherapy, pharmacotherapy, laws, forensic psychiatry, and addiction. So let me introduce a very famous star of psychiatry in Egypt, Professor Mumtaz Abdul Wahab.
Thank you very much, Professor Hisham Rami. He is one of my dearest friends, and so he is very generous in introducing me. You know all, Professor Hisham Rami is the General Secretary of the Egyptian Psychiatric Association. He is also the Vice General Secretary of the Arab Federation of Psychiatrists. He is the Vice President of Egyptian Society for Cognitive Behavioral Therapy. He has many activities. He is now the chief editor of the Arab Journal of Psychiatry. And thank you again, Professor Hisham. My talk today is about the problem of the turbulent world. We are living in changing world. We are surrounded by problems, by wars, by pandemics, by something very stressful to our life. And this will affect, of course, our mental health and our general health. So my talk will be about this subject. The crises that we are faced now are in the pandemic of COVID-19, the economic recession which happened after this pandemic, the political repression, the wars and the preparation for the wars, the nuclear weapons, the climate change, which is very, very stressful problem now. We are facing it. About COVID-19 pandemic as 2022, COVID-19 and its economic and societal consequences continue to pose a critical threat to the world. Although it started in 2019, but its effect is still till now. She's still affecting our economic condition. There is a compound social fracture, geopolitical tensions, because there will be discrepancy between rich countries and poor countries in vaccination in the developing At times of writing this lecture, 15 countries had vaccinated more than 70% of their population, while there are 52 countries, poor countries, vaccinated only 26%. So this will make a very discrepancy between the poor and the rich countries. By 2024, the next year, developing economies, excluding China, will have fallen 5.5% below the pre-pandemic expected growth. This will lead to many people will lose their occupations, and it will be very hard work for a hard time for us. The world continues to grapple with the effect of COVID-19 on public health. At the start of 2022, 5.4 million deaths from COVID had been reported globally, out of 282 million confirmed cases. And the world lost 5.5 million deaths in this year. Moreover, a significant proportion of those infected by COVID has long-lasting symptoms. Some 10% show persistent ill health for 3 months after having the disease. Disparities in the progress of vaccination have created a divergent economic recovery that increase risk of re-existing social cleavage and geopolitical tensions. These tensions and the economic overhang of the pandemic will make it difficult to ensure a coordinated and sufficiently rapid approach to global challenges, most notably climate change. The risk for economic recovery, rising commodity prices, inflation, and debt are emerging risks. All of us are suffering now from the increase in the price of everything. At the start of 2023, COVID-19 crisis is still ongoing and its economic reductions continue to be felt. The global economic recovery from this recession caused by the responses to COVID-19 pandemic continues but is still slowing. Risks to economic growth are considerable. After contractions of 3.1% in 2020, decreased global economic growth is expected to reach 5.9% in 2021 and slow to 4.9, about 5% in 2022. The income disparities risk increase the polarization and resentment within these societies. This is the first crisis we are facing. The second one is the climate changes. The planet cannot wait. Climate action failure, extreme weather, and biodiversity loss also rank as the 3 most potentially severe risks for the next decades. As we see, the temperature of the Earth are increasing, and this will increase the deaths and the health problems. The temperature-related death and illness, future increase in temperature-related deaths, and there will be even a small difference from seasonal average temperature, but result in illness and death. Even the small change in the temperature will cause death and illness. And increase, but there is there will be change in the tolerance to extreme heat. We are adapted to the increase in the heat, and this will reduce the rate of deaths and the illness after a while. Still, we are using now air condition, and this will improve our life. Air quality impacts. The air quality itself will be changed. There will be exacerbated in ozone health impact, and there will be increased health impact from wildfires. The wildfires are increasing. They emit fine particles, dusts, and ozone precursors that will increase the risk of premature births and premature death and adverse chronic and acute cardiovascular and respiratory health outcomes. There is worsened allergic and asthmatic conditions. The people who are suffering from allergy and chest problems, they will suffer more and more from the change in the pollution in the air. There is risk for climate action failure. Although there was COVID-26 and they make an agreement to decrease the temperature of the Earth by 1.5 degree in the next years. This was in 2016. Still, it failed. They failed to collect money and to proceed in their plans, and it failed. The impacts of extreme events on the human health, there will be increased exposure to extreme events. The health impact associated with climate-related change in exposure to extreme events include death, injury, illness, lead to exacerbation of the underlying medical conditions and adverse effects on the mental health. There will be disruption of the essential infrastructure. The hospital and the staff, the medical staff, all will be suffering from these changes. There will be vulnerability to coastal flooding, which will also affect the population, especially those who are living in the, who are suffering from disabilities or other access or functional needs. Also, there will be increase in vector-borne diseases, changing the distribution of vector and vector-borne disease. There will be earlier tick activity, and there will be changing in the mosquito-borne disease dynamics, and there will be emergence of new vector-borne pathogens and seasonal and geographic changes in water-borne illness risk. There will also water infrastructure failure, increased risk of food-borne illness. The food safety will be affected and the nutrition will be affected. There will be chemical contamination of the food chain, and there will be even difficulty to transfer these the food from one country to one country. We see the war between Ukraine and Russia are affecting the supply of food for many countries. There will be rising of carbon dioxide will lower the nutritional value of food, and there will be extreme weather will limit access to safe food. Climate change will threats will result in mental health consequences. There will be depression, there will be post-traumatic disorder, there will be general anxiety, which often occur at the same time. Extreme heat will increase the risk for people with mental illness. We know all the neuroleptic malignant syndrome for people who are receiving major tranquilizer or antipsychotics with the increase of the temperature. There are special factors which affect health impact. The health impact will vary with age. Of course, the people who are older in age or younger in age will be affected and will be at higher risk. Children and old age, of course, are most vulnerable to these changes. Vulnerability will vary according to the time and in the place. Specific community that rely on natural environment, who don't have air condition and don't have the facilities of the modern life, of course, will be more affected. There are social determinants of health interact with climate factors to affect health risk. Geopolitical tensions, the problems between the different countries, the China and the Russia and the struggle between them, the China will increase the military powerness and changing the balance of power in the Western Pacific, and the United States is strengthening alliance focused on a specific response, most recently with Australia, United Kingdom. All this will affect and are putting stress on us. Countries may drive regional convergence at expense of global integration. Instead of being integrating together and helping each other, usually we are, according to the stresses and the problems, we are diverging, and there is a separation and no cooperation between different countries. The war is now everywhere. There is war all over the world between the countries and inside the countries between different people, and it has a numerous and tragic impact both directly and indirectly on public health. It will cause adverse effect on medical care and public health service. It will cause damage to the environment. It refugees and internally displaced persons. Now in Egypt only, there are more than 9 million refugees from different Arab countries due to the war. Diversion of human and financial resource, promotion of violence. As estimated, 200 million military personnel and civilians were killed as direct result of war during the 20th century. As the century progressed, an increasing percentage of those killed were civilized. Adverse effect on medical care and public health service. Physicians and nurses and other health workers are killed or injured according to the war, or they flee. Damage to the clinics and the hospital. If we are following the news from Sudan, we can see as a result now most of the hospitals and the clinics are out of service. There is reduced supplies of medications and vaccines. There will be destruction of power supply, sewage treatment, and other protection of food and water supplies. Also, the problem now that most of the countries are preventing people to move from one country to another country. And with this will increase the insecurity. And as a result of the economic hardship, people want to change their countries, but usually the other countries are refusing to receive them. There are 40 million refugees worldwide. 12 million children left homeless from 1990 to 2000. The vast majority are fleeing violence and war. Human rights violation, of course, in the world, there will be assault on civilians, there will be ethnic cleanings, there will be a violation of the medical neutrality, there will be diversion of the economic resources to get weapons and to supply the army, and this also will make more economic troubles and reduction in the global funds. The war in Iraq and Afghanistan have cost approximately $600 billion in federal outlays over 5 years. And we can remember how much this money can improve the life of the human being if they are expended in something other than war. The total cost of this war estimated by Stiglitz will amount to $3 trillion, 5 times as much. Using these estimates, the total cost have been approximately $600 billion a year. This is the nuclear stockpiles. In the United States, there are 2,500 nuclear weapons, and you see different, most of the world countries have this nuclear stock. The nuclear winter, as a result of the nuclear weapon, could lead to cooling of the Earth's surface by clouds of shoots and dust produced by the explosions, leading to severe shortage of food. Recent studies have predicted that even detonation of a small number of weapons would lead to protracted and widespread cooling. How we can create a world without war, improving the condition in which the people live, Millennium Development Goals, eradicating the extreme poverty and hunger, achieving universal primary education, promoting empowerment of women, but all this need funds, which we don't have, and we spend our money on weapons and on nuclear weapons. We have to control weapons and decrease the military expenditure, which is impossible. Creating a culture peace in which conflicts are settled non-violently, United Nations and the International Court of Justice, International Criminal Court. I think they are not effective enough. Their role is not clear. We have many challenges to improve our mental health and our health in all these stresses. At first, we have inadequate community care. We have the stigma of the mental illness, which makes the people with mental disorder are subjected to discrimination and abuse. The human resources, there are far too few trained professionals to meet the needs. With the number of doctors, the number of psychiatrists, the number of social workers, the number of psychologists, the nurses are still too much below our needs. Dealing with common mental disorder and addressing disturbed society needs for greater attention. This could include a strategy of shifting psychologists from hospitals into community. The infrastructure. Some mental health facilities are not fit for human habitations and require revitalization or new facilities built. Still, we are concentrating on treatment, but the effort for prevention is still not in our mind. We don't emphasize on prevention, which is very important more than treatment. What we have to do? We have to do priority to the mental health in the annual performance plans. We have to regulate mental health care environment in a manner that makes the best possible mental health care, treatment available, and rehabilitation service available to the population. Coordinates access to mental health care, treatment, and rehabilitation service to various categories of mental health care users. Integrate the provision of mental health care service into general health service environment. Regulate access and provide mental health care, treatment, and rehabilitation service to be voluntary assisted and involuntary health care users. And also we have to clarify the rights and obligations of mental health care users and obligations of mental health care providers. We have to regulate the manner in which property of the persons with mental illness and persons with severe or profound intellectual disability may be dealt with a court of law. We have to provide equitable, cost-effective, and evidence-based interventions and thereby ensure that mental health is available to all who need it. We have to integrate mental health and substance abuse service into general health service environment. We have to provide mental health and substance abuse care to people within communities while referring to higher health care levels where clinically required, ensuring that all users of mental health service participate in planning, implementation, monitoring, and evaluation of mental health service and programs. We have to foster person-centered recovery paradigm, increase the human resources to address mental health needs throughout countries. We have to develop and strengthen the human capacity for prevention, detection, and care, treatment, and rehabilitation of mental and substance use disorder, and build a link with traditional and complementary health practitioners to provide physical infrastructure that is conducive to the needs of the human rights, to reduce the cost and increase the efficacy of mental health interventions, to establish comprehensive mental health surveillance mechanism, health information system to assist policy and planning, to develop and supporting research and innovation in mental health, using outputs from Summit to finalize the mental health policy framework and assist with its implementation and monitoring. And consequently, to develop and implement mental health service delivery platform based on community and district-based models. To implement with vigorous the health sector mini-drug master plan, to establish at least one specialist mental health team in each district, adequately fund mental health service as pre-WHO recommendation, embed and increase the mental health human resources within the National Human Resource Plan, to develop a fit-for-purpose plan for mental health infrastructure at all levels, revise the norms and the standards in line with the service delivery platform, strengthen the mental health review board, establish a national surveillance system and appropriate monitoring and evaluation system for mental health care integrated into National Health Information System, establish a national suicide prevention program, strengthening links with traditional, complementary, and faith-based healers and non-governmental organizations. Thank you. Now I have the honor to introduce our next speaker, Professor Charlotte Kamel. She is Professor of Psychiatry in the Royal College of Surgeons of Ireland, Medical University of Bahrain in Bahrain. She has many activities in education and training, and since 1980, she was started her training in University Hospital of Liverpool, London, in Gaze, and then obtained Diploma of Psychiatry from Royal College of Psychiatrists 1982, and she was a membership in 1984, and she got her fellowship in 1996. Welcome, Dr. Charlotte. She will talk about the factitious disorders, a comprehensive review.
Thank you. Thank you very much, Professor Mumtaz. And I thank the WPA Thematic Congress in Abu Dhabi, especially Dr. Medhat Saleh, for inviting me and sharing with all my colleagues. It's my honor to talk with all these professors from my original country, Egypt. So I am proud to be talking to you. My title of my presentation is Factitious Disorder. I know it's a heavy, word. I became interested in that topic during my training as a liaison psychiatric trainee in King's College in London, because I used to be referred many cases. The physician and surgeon don't know what to do with them. And, at that time, I was still young trainee, so I didn't know exactly what is it, but now I can comprehend that. And in the DSM-5 and ICD-11, it devoted a big explanation. So we will talk about the definition, what is factitious, what does it mean, epidemiology, etiology, warning signs, historical background, diagnosis and clinical features, how we can diagnose it, types of factitious, differential diagnosis, course prognosis, treatment. I'll try to be quick to give time for questions. The definition of factitious disease is the intentional production or feigning of disease, falsification, in oneself to relieve emotional distress by assuming role of a sick person. Although the self-induction of the disease is a conscious act, the underlying motivation is unconscious. And in Arabic, it's called al-marad al-mufta'al, or at-tamarud, playing the sick role. So they induce the disease for some unconscious psychological conflicts. It's a serious mental health disorder, okay? They are not liars or, bad people. No, they are suffering from serious mental health disorder in which the person appears sick after producing physical or mental illness. People with, it could be physical and it could be mental illness, mimicking mental illness. People with factitious disorder deliberately produce symptoms of an illness for the purpose of receiving care and attention. They are lacking very much in, in having empathy and sympathy. Symptoms are not intended to get them practical benefits. The gain is believed to be mainly psychological. It is considered mental illness, as we said. It's associated with severe emotional difficulties and patients' likelihood of harming themselves by continuing to produce more symptoms, resulting in getting themselves unnecessary procedures and surgeries. They are extremely difficult to recognize. It's not easy to recognize them. They don't appear different from patients with authentic causes of similar symptoms. They present with abdominal pain, they present with neurological symptoms, they present with anything. So doctors in general hospitals cannot differentiate. They have symptoms presented by individuals. Because their psychiatric abnormalities are not appreciated, doctors and nurses have a low index of suspicion. And here, this is the role we have to play in educating our colleagues in general hospitals. If they don't find, a diagnosis, no need to do something. But, to just conduct operations after operations for some complaints which is vague and not supported by evidence-based, it's a problem. People with factitious disorder also tend to seek treatment at many different healthcare facilities, resulting in statistics that are misleading, especially in USA. They move from one area to the other. So there is no way to follow them up or get a full past history, which they hide when they present their problem. They don't present it, sure. This is a proposed pathogenesis for factitious disease. Early deprivation or trauma is the main, underlying causative factor, which goes to the unconscious mind. So they have, they have learned to suffer in childhood and adolescence, and this suffering provides meaning to their life, and it stays in their unconscious mind. So in their conscious mind, they try to induce or fake illness, consult physical for relief of self-induced symptoms, assume sick role. Relief of emotional distress. So this seeking and reporting complaints and inducing complaints, actually they can harm themselves. ICD-11, have quoted these problems, either factitious disorder imposed on self or imposed on another, especially children. And I'm sure you all read in magazines and journals from time to time how kids are, harmed by their mothers or fathers, and unspecified. And factitious disorder in ICD-11 is under disorders of adult personality and behavior. It goes with impulse control, with insomnia, with circadian rhythm, so it's, categorized in ICD-11 under this category. Also in DSM-5, factitious disorder, which is previously Munchausen, I'll talk about this later, is now classified in DSM-5 under somatic symptoms and related disorders. Description of disorder in DSM-5 has changed from motivation to assume the sick role to deceptive behavior, which is evident in the absence of external incentives. So both ICD-11 and DSM-5 are paying a big interest in this because it costs hospitals a lot of money. People have, all sorts of MRI, CT scan, tests, treatments, operation, interventions. What is the history? I became interested in the historical background. Is it a new thing we discovered? I want to ask any one of you, have anyone received a referral from a physician or surgeon that he doesn't know what's wrong with the patient, he suspects psychological reason? How many? All the time? All of you? I find it rare. I find it rare. And the literature said that, you know, they don't recognize it's gone under unspecific, atypical, you know what I mean? Or, you know, they have actual interventions. So the word factitious are found that from the 2nd century, a Roman physician, Claudius Galen, first mentioned feigned diseases, how to detect them. He said feigned diseases. But in 1843, Hector Gavin, an Irish physician, first used the term factitious. And in 1943, Karl Menninger discussed compulsion of certain neurotic character to secure repeated surgical operations. And in 1951, Asher created the name Munchausen syndrome, the most extreme form of factitious disorders. But I want to tell you that this name has been canceled now from both ICD-11 and DSM-5. So how common it is? 5% of physician-patient encounter may involve factitious diseases, with the reference mentioned. 9% of cases of fevers of unknown origin or recurrent infection were self-induced. It is estimated that about 1% of those admitted to hospitals are believed to have this disorder. It's likely to be underreported, and this is, you know, 1% reported by American Psychiatric Association. 2 main groups of people affected. Of course, women. Women between 20 and 40, okay? And those with healthcare background, whether men or women. Healthcare background, they know everything about health and how to manipulate doctors. Onset of illness, usually in early adulthood, often following hospitalization for a medical or psychiatric illness, episodic illness, but it can become lifelong and chronic. Overall prognosis is poor. And for the victims of factitious disorder, children, the mortality rate can be between 6% to 22%. And this is why there are, you know, now a lot of talk about this disorder, because the effect on the younger population. Poisoning and suffocation are the most common forms of harms. Types of factitious disorder, some with mostly psychological symptoms. They mimic, you know, psychological symptom, hallucination, delusion, schizophrenic, Ganser syndrome, sometimes called prison psychosis. But mostly it is physical symptom, chest pain, stomach problem, as it used to be Munchausen. By the way, Munchausen was a baron in 18th century German officer, known to be embellishing stories about his life and experience, exaggerating and creating stories. So the term was after him. There are 2 types. Type imposed on self include falsifying psychological physical symptoms, and the other type imposed on others, usually elderly, children, sick people in the house, disabled people, pets, even pets, you know, have been, you know, affected. It most often occurs in mothers, although it can occur in fathers who intentionally harm their children in order to receive attention. Of course, the diagnosis here is given to the victim. It's not given to the victim, it's given to the, you know, perpetrator, mother or father, usually. Mechanism employed include self-induced infections, superstitious ingestion of medicines, self-induced injury, phlebotomy, induced bleeding from parts of the body, thermometer manipulation. They put the thermometer in hot water, so they induce fever. So when they appear in casualty department, and usually they go to casualty departments rather than going to ordinary clinics in order to impress doctors that it's serious. And the simulation of clinical manifestation of specific diseases. So how do they, what is the, you know, categories? Exaggerating existing symptoms. Maybe they have an actual medical or psychological condition and they exaggerate the presentation. Making up stories is more common, and faking symptoms, causing self-harm to themselves or other people. Tampering may manipulate medical instrument to score result, as we said. What are the warning signs? Dramatic, but how can we discover it? It's dramatic but inconsistent medical history. Yani they are not consistent. Unclear symptoms that are not controllable, become more severe on change once treatment has begun. Unpredictable relapses following improvement. Extensive knowledge of hospitals or medical terminology. They read textbooks. They read, they know doctors and nurses what they want to listen to. Presence of many surgical scars. Appearance of new or additional symptoms following negative test results. So regarding surgical scars, that was one of the cases I saw in Guy's Hospital. A patient, 25 years old, admitted to hospital for severe acute abdominal pain, requesting laparotomy. And when, she was referred to obstetrician and admitted the second day, they found that her abdomen is like a map. She had previously 12 or 15 cuts for laparotomy, like a map. And the obstetrician said, no way, he tried to investigate, he found no reason. And this is the main case I saw that was very, very serious. A girl, 25 years old, having every year one laparotomy. Continuation, presence of symptoms only when observed. If they complain of pain and get admitted, if the nurse is observing them, the pain is not there. They are living their lives. Willingness and eagerness to have medical test, operation, procedure, they accept anything. Reluctance by the patient to allow healthcare professional to meet family members, friends, or give reports about their previous contacts with health services. They become very angry if asked to provide this data. Refusal of psychiatric or psychological evaluation, of course, they deny completely that they have any problem. And forecasting negative medical outcomes despite no evidence, patient sabotaging discharge plan. The worst thing, if you tell these patients that you don't have anything, because immediately they will rage with the medical facility and the doctors. This is some of the causes: trauma, family dysfunction, social isolation, early chronic medical illness, professional experience in healthcare, as we said. But the exact cause is not known up till now. Symptoms lie about or mimic symptom, hurt themselves, alter diagnostic test, as we mentioned, be willing to undergo painful or risky test. They will accept any intervention. Which is very strange, and they are not worried. Everyone before operation, a patient is scared, and they are welcoming. So it has to make, doctors suspicious. Consequences of factitious behavior is very serious. Doctors prescribe unnecessary procedures and therapies that may result in iatrogenic disease. Damage to patients from doctors exceed harm resulting from patient self-induced illness. Unnecessary operation, side effects to medication, whatever affect them. And ethical conflicts. If the patient with factitious disease mistakenly diagnosed as having psychogenic pain when in fact symptoms were caused by an overlooked physical disease, it involves, problem. So we already mentioned that. Differential diagnosis. There are many conditions which, look like each other, but we'll talk about them now. We have factitious disorder, malingering, and all of us during our work as psychiatrists, we saw malingerers, somatization, and hypochondriasis. Factitious disorder, we said conscious, intentional feigning. They know they are inducing symptoms. They know they are inducing fever. They know they are making themselves injured or bleed or do it to others. Malingering. Malingering, conscious and intentional production or exaggeration of symptom for material gain. Either escape from military service or for drug abuse or to get money or anything. Escape from punishment. So they have an intention. Factitious disorder, they are not looking for reward. They don't want anything. They just induce the symptom and make doctors suffer and nurses. This is their only gain from the whole process. Bodily distress disorder, in ICD-11, previously called somatoform. This is recurrent and multiple actual symptom, pain, gastrointestinal, pseudoneurological, while in factitious, this is, believed to be due to unconscious expression of suppressed emotional conflict or stress. But they don't induce anything. They don't induce by themselves. They just have some unconscious or suppressed emotional conflict expressed in symptoms. They don't feign or deceive doctors or deceive hospitals. Unlike factitious disease, symptoms are not created by voluntary conscious behavior, and they don't falsify symptom or mislead others. So somatic symptom and related disorder in DSM-5 is 3 criteria: health, anxiety, disproportionate, persistent concerns about medical seriousness, excessive time, energy devoted to symptoms. But they don't have gain, and they don't lie. They feel it. Hypochondriasis, obsession with fears that one has serious undiagnosed disease, presumably based on misinterpretation of bodily sensation. In ICD-11, hypochondriasis has been placed now among the group of obsessive compulsive and related disorders because of the repetitive fear expressed by the patients. So they said it's more, like compulsive or obsessional. In DSM-5 has retained hypochondriasis within the cluster of somatic symptom and related disorder. They didn't change the name. This table is very interesting. I think all our colleagues in general services, we need to explain it to them. And it's how to differentiate between somatic symptom, the related disorder, factitious, and malingering. So we'll start from the left to the right, or the right to the left. We'll start from here. Unclear or unexplained medical symptom. A patient presenting with unclear symptom. We have to know whether the symptom production unconscious or conscious or intentional. Motivation, if in somatic symptom and related disorders, the symptom production is unconscious. Motivation is unconscious. The gain is none. And so the diagnosis is somatic symptom and related disorder. Is somatic symptom due to unconscious stress or conflict. Factitious disorder. Symptom production is conscious. They know what they are doing. Motivation is unconscious. And then the gain is not external. It's not material. It's internal. Primary chief goal is psychological. Then we'll go to malingering. Symptom production intentional. Motivation intentional. External motivation or external gain, it will be malingering. So this is, table, is very simple to differentiate between the 3 conditions. There is another condition, we do see it in general hospital, maybe much less now, which is conversion disorders, have been grouped with dissociative disorders in ICD-11. Under only dissociative neurological symptom disorder, not any kind of disorder, in DSM-5 and ICD-11. So approaches to treatment now. I became interested in this doctor role and patient role because our usual, impression is that patient present with illness or unhappiness and, the doctor treat him, isn't it? The doctor do the best to help, to improve the situation. So I will just mention, it was very nice, a traditional doctor-patient relationship. Doctor must act on behalf or in the best interest of patient welfare, including curing patient whenever possible, not harming and maintaining patient's confidence. So what about the patient's role? 3 basic features. It is not the sick person's fault that he is sick. Patients are excused from their ordinary daily obligation, expectation. Patients must make every attempt to regain health, including requirement to their physician to detect, explain supposed cause of their disease. there is no medical treatment for factitious disease. It's all counseling, psychotherapy, CBT that Dr. Reham Ali mentioned to us. There is no medication that can help except if there is a comorbid condition, depression or anxiety. So the first goal of treatment is to change the person's behavior and reduce their misuse of medical resources. In case of factitious disorder imposed on another, the main goal is to ensure safety and protection of any real or potential victims. And this is why it has to be identified at an early stage. Once the first goal is met, treatment aims to resolve any underlying psychological issues that may be causing the behavior. Primary treatment, as we said, psychotherapy, changing thinking and behavior of the individual by cognitive behavioral therapy. Family therapy also may help teaching family members not to reward or reinforce behavior of the person. No medication to treat this problem. The sick role of the patient is attained via fraudulent means. They deceive doctors, you know. They induce the symptom and they offer it to the doctor, and they enjoy seeing healthcare professionals not knowing what's happening. You know, they derive pleasure from this. And it helps them to relieve their internal conflicts. By withholding information unconsciously regarding cause of disease, as a result, physician is not aware of the above, and so he does not suspect or know all the facts. As a result of unneeded, inappropriate diagnostic tests and therapies are prescribed, willingly accepted by patients. They will accept any intervention, okay? Even if not validated. Anything they want to do. And this brings the concept of they induce suffering to themselves, you know, physical suffering. Factitious disease patients' partners in the illness is the doctor. Doctor play a big role in encouraging patients to continue like this by helping them and doing procedures unnecessary. Greatest damage is due to doctor action rather than to action by the patient. Confrontation is completely forbidden. And you all know, you all psychiatrists know, if we tell our patient we don't believe you, what he will do? He will open the door and go away, isn't it? Confrontation doesn't work in psychiatry. And if conducted, it has to be after building a long relationship with the doctor and, you know, so they can trust him. And, you know, physicians don't have the time to keep, you know, spoiling patients and pampering them. Patient is desperate, need of help, understanding and supportive attitude by staff make it possible for the patient to cope and live through shame and shattered self-image that will result from confrontation. However, after building a relationship with the patient, let the patient know what you suspect without outright accusation. Support suspicion with facts. Yani tell him we did this investigation and we can't find anything. We will keep on going, but you know, until we discover how to help you. Provide empathic and face-saving comments such as maybe you took it during sleep if he swallowed tablets or he injured himself. What you did was a cry for help. We understand. And you know, you all psychiatrists, and you know how these words are met by patients. We realize you must be in great distress. We want to continue to take care of you. So it has to be, you know, psychologically approached to a great extent. Avoid the probing to uncover patient underlying feelings. Psychoanalysis here is not indicated because you don't want to break the defenses. You want to keep them until you know the patient admit by himself and the motivation. So we don't want to break the defenses that are essential to his or her function. Assure patient only those who need to know will be informed. It's confidential. Make sure that staff demonstrate continued acceptance of the patient as a person worthy of help. Attending physician should not abandon patient, should continue to show interest and concern. Encourage psychiatric help. If the patient resists, don't force the issue. So it means that we should educate in a bit our medical and surgical colleagues about how to approach these patients. Because the minute you tell them, I refer you to psychiatrist, it means that you don't want to do anything for them. So I know it's very hard for them, but this is the only way they can do, and they can avoid the complications of iatrogenic disease, because many complications come from unnecessary procedures, isn't it? So this is the only way. What is the prognosis? As I said before, prognosis is not good. It's a long-standing condition, especially with patients who jump from one hospital to the other and no consistent medical records. There is no known way to prevent it. It may be helpful to start treatment in people as soon as they begin to have their symptoms. This is the last slide in the presentation. There is a great importance for recognizing patients with factitious disorders. Medical mistakes and iatrogenic disease are avoided. The costs are enormous. The costs are very high. USA estimated, very high, cost for these problems. The facilitator of factitious disease in the Western world is good medical insurance. Because with insurance, you can do all the MRIs and repeat and all. And do you remember, even before this, I mean, I'm an old woman, I started early in medicine. And I used to see the patients coming to the clinic with a stack of prescriptions and investigations. And I didn't know at that time, I say, oh my God, this is a very serious patient. When it turned up that, he's only, but we didn't understand, wasn't psychiatrist at that time. But I remember that. Now it's converted into electronic, MRI, CT scan, blood test, you name it, variety, they all to go specialities. Thank you for your good listening, and I'm sorry to prolong the presentation.
Thank you very much, Professor Dr. Charlotte. Now we just have 2 minutes for discussion. So the floor is open now for discussion. Any question? Everything is very clear. Dr. Tala.
Yes, Dr. Charlotte. I think sometimes it's very difficult to differentiate between factitious disorder and the malignant, especially if the patient hides the external motivation sometimes. So I think we need to approach the family or significant others to know exactly what's going on. And I admit that they're very difficult to find out the external. Sometimes the patient hide it, especially if it is psychiatric factitious disorder, because there is no investigation for us. We have nothing to do except we have to believe what the patient say about himself. Okay? This is the problem. And the more problem is factitious disorder by proxy. When you inflict on your child or something. This is maybe easier to diagnose than the factitious disorder itself. What's your comment?
Yeah, I agree with you, of course. And this is why, it is discussed now. And they devoted a big section in ICD 11 and DSM-5. And also the general hospitals. The general hospitals have in the West also, because the insurance is very high, and these patients, are costing insurance very high for non-specific diagnosis. So it is very difficult because they are deceiving, the medical personnel. I mean, and this is why, we emphasized, the doctor role and patient role. Patients have to be honest. And this is the role of liaison psychiatry. I mean, liaison psychiatry is a very important branch. The availabilities of a liaison psychiatrist on site for each specialty, and there is specialized liaison psychiatry. PA liaison psychiatry for cardiac, for perinatal, for surgical, general liaison psychiatry. So it's a very important job. I feel we have to, spread it in our countries. To overcome these problems, because surgeons and medical doctors are busy, and their knowledge of psychology is not like psychiatrists. They don't suspect patients. They take the complaint at face value and try to do the investigation very costly. So you don't blame them. It's very hard for them.
Also, not easy for the psychiatrist to diagnose it for ethical consideration. And the patient tries. He might sue you legally that of negligence, doctor does not like to listen to me, something like that.
Exactly, yes. Yeah, it needs great awareness and tackling of the problem, gently, building relationship with that patient rather than getting rid of him. هو اللي بيحصل إنه the doctors get fed up, with a patient complain like this. أكيد medical and surgeon, they want to get rid of the patient. He keep complaining of the same complaints, not treated, not responding to treatment. So it's hard. And if you have seen one patient like this, it's drive our life mad.
Any other question? Okay.
Thank you so much, Dr. Chal. Very nice presentation. Just a quick question. I've done liaison psychiatry for many years, and patients don't like the terms we use. Factitious, malingering, even dissociation or conversion, because it all implies we don't believe them. So the term we started to introduce in liaison psychiatry is medically unexplained symptoms. What do you think of the term? Changing the term, will that help in the management of the patients?
Yes, thank you very much. Yes, I agree that it's how the first doctor that sees the patient deal with it. If he deal with it properly and try to understand the patients, and doctor is a doctor. I mean, even us psychiatrists, we have some awareness of medical, of other branches. Being a doctor, you have to be aware. And maybe it's our part, we have to spread more mental health awareness, as Professor Mumtaz said, in general hospitals. General hospital awareness of psychiatry is very little. Maybe we have to spread more awareness for these people. So to deal with cases like this, which is serious. When a child gets killed by his mother, it's detrimental to the mother and to the family and to all of us. We feel very, it's a humanitarian crime that we could not prevent, even if we didn't participate.
Doc, this is a question for you. Hello? Can you hear? Yeah, okay. Dr. Mumtaz, this is a question for you. The picture, the global picture that you presented is pretty scary or intimidating, and you give some solutions, from the mental health, what to do. But this might be a naive question, or, is there any hope? In your opinion?
I think very different, of course. You have a right. The hope is very little. But I think each country can improve the situation according to the facilities and what she can do for their patient. But the cooperation between different countries and to decrease and to do a world without a war and to improve the climate weather and to put the people to cooperate, different countries to cooperate with each other, I think it is obvious as you Utopia.
Thank you for wonderful talks. The question I'm looking at in a different way is, do they ever, as someone with factitious disorder, do they ever burn out after 20, 30 years of constantly, having to go to hospitals, get some reassurance? Do they ever just burn out of the illness? It's sort of like some of the autoimmune diseases, rheumatoid arthritis. Eventually, it's just the bones are set the way they're going to be set, and not going to, they live with it. Versus constantly going back to the hospital.
Yeah, I searched literature, to be honest, the outcome, the final outcome for this factitious is not documented. However, I came across a case, one of our senior colleagues in Jordan, he said that, a patient went all over the world, a rich patient with this factitious. And then she came back to Jordan and told them that, khalas, she wants help. She admits there is something wrong and she wants help. And he did a process of psychotherapy to her, but that was after 20 years going around. And she responded well. But this is individual case, but it's not reported, to be honest. What is the outcome? Because they don't stay with one service. I mean, literature, they say they jump from one place to the other, so there is no continuity of records. Thank you. And I want to ask you,
thank you for the brilliant talks from this end. Hi. Can you hear me? Just wanted to on the topic of factitious disorder. From what you've described in your talk, it seems like it's very much a social issue as well, describing the trauma. Is there any, is there any talks or discussions or any information around other interdisciplinary working? For instance, mental health liaison nurses or mental health liaison social workers? Because the trauma or the safeguarding issue that you've described with children particularly, or elderly vulnerable adults, would come under the social services remit. Would you be able to shed some light on that, please? Thank you.
You mean liaison psychiatry attending to that?
No, because safeguarding would be more of a social services role or a social work role. If there's issues around trauma, so we would address them via psychotherapy or alternative therapies, as you've described. But issues that are more of a risk and a safeguarding issue, is there a description or talk around having more professionals on board for this kind of work?
It will, professional, psychiatric personnel are aware of this and they will help. But the problem is that, the patients are not referred. Patients, first of all, are not referred. Physicians do not diagnose factitious. You know what I mean? And if they diagnose it, patients refuse to see psychiatric personnel.
That's what I mentioned with regards to the social worker or the mental health liaison nurses, because then it's a softer approach perhaps for them to face and say, well, I don't want to go and see a psychiatrist, because it's a big stigma as well to them.
I mean, maybe if they, maybe doctors are frightening, maybe, the rest of the healthcare professionals, psychologists, counselors, nurses, you are right, yes. Maybe they are near, and especially nurses, they spend long time with patients. So if they can, and I know that nurses, at least in Bahrain, I know our nurses are very high standard. They are British standards, nurses in Bahrain, and they take full history from the patients and they approach and build a relationship. So it's really the problem, I think, in connection between all, parties, general psychiatry, liaison, you know what I mean? And especially all healthcare professionals. You are right.
Thank you.
Yeah, thanks.
Thank you. Thank you to all speakers. I have a quick question regarding the last talk for teachers. So, Doctor, are you aware, is there any guideline, official recommendation, or any group who is working like legally, doctors, surgeons, to require psychological assessment of patients with not clear medical condition?
Yeah, I agree with you entirely. It has to be, but this needs awareness on our partners, our colleagues.
Are there such guidelines or?
No clear guidelines. Maybe because, the ICD-11 and DSM-5 now
are emphasizing the seriousness of the problem, because they discover that insurance money is going on investigations, very expensive investigations, and maybe some complaints in the legal health authorities about complications, consequences, you know. So you are right, we need to do some clear guidelines. Yeah, not us, yani, international, WHO, APA. Dr. Mumtaz, I have a question for you.
Shukran jazilan. We have to finish our session because I think there is another session. It is their time, and we passed our time by more than 15 minutes. I have to thank Dr. Rayam, Professor Charlotte, for their very, very interesting lectures, and wait to see you, inshallah, many times next. And we have to offer something as a gift from the conference.